When we started to do outreach clinics, a lot of patients that we were seeing were ones that had very advanced disease. It's really hard to think that sometimes I go in and say, "Hi, I'm Laura Morsetter, and you need to start dialysis." And that's something that's not fun to share with people. I am an associate professor at the University of Wisconsin in Madison. The We're United for Kidney Health campaign is such a great addition to our field. And so this campaign really hits on all the important points in being able to bring about change. The priority that speaks to me most is to intervene earlier to prevent, diagnose, coordinate care, and educate. One of the clinical areas that gave me an opportunity to take care of a population that often is vulnerable was the prison population. And in that system, it's often one of the first times that people are hooked up to healthcare. So some of them have just newly diagnosed high blood pressure and they're very young. That education that I can provide at a younger age, in a place where maybe they haven't had heart or kidney effects from their hypertension, really makes a difference. I do get a chance in those patients to talk to them about the importance of their diet, their blood pressure, avoiding diabetes, and I hope that that then could be a message that's brought forth because most of them have never heard any of that before. With this program, it's an example of where we can get to people earlier and really intervene on their kidney disease. We often think of ourselves as helping a particular patient or a particular population, but really we can also think of ourselves as providing education to partners and taking care of our patients. These are patients that I don't see in my clinic in a way that I have that opportunity, but if we can educate those primary care doctors to be able to start earlier and prevent the things that happen later, that could be such a good place to intervene. I'm Dr. Morsetter, and I'm for Kidney Health.
Welcome to Kidney Week. It is hard to believe an entire year has passed since Kidney Week 2020. Together, wherever you may be tuning in from today, let us consider for a moment how we, as a community, have led through a crisis, a public health crisis that has cost millions of lives. We might begin by reflecting and considering how it spread. Silently at first, with a desperate need, an urgent need to gather more information and knowledge about its cause and about how it progresses. Asymptomatic in many until it is too late, which perhaps has been one of the most difficult aspects. Amplified on other organ systems, the heart, blood vessels, mental health, affecting whole families and communities, and having a major economic impact, and exacerbating the excess burden of disease in communities of color and vulnerable global populations, where social determinants of health play a major role in disease prevalence, diagnosis, access to the best treatments, and outcome. I am so proud of our community in the midst of the crisis to see that kidney professionals are leading the way out of this crisis. And our community, each of you, members of the kidney care and research discovery teams, have come together, have stood up shoulder to shoulder, committed to ensure our patients receive the best possible care. The public health crisis I am referring to is not COVID-19. It is kidney disease. And in the midst of another public health crisis, which is still very much present, long after the pots and pans have gone silent, and in many areas replaced by angry protests, now is the moment to take lessons learned and lessons we are learning from the pandemic and apply them to conquer kidney disease. One question that comes up, especially from those outside our community, Is kidney disease really a public health crisis? Am I exaggerating? Facts speak for themselves. There are 850 million people affected with kidney disease worldwide. There are 37 million individuals living in the United States alone, and the numbers are no better throughout the world. 90% of people with kidney disease do not know they have it. And here in the US, a third of the population, or 33% of all Americans, are at risk of kidney disease. And these numbers are similar in other parts of the world. If you have kidney failure and start dialysis, you have a 35% chance of surviving 5 years, a prognosis that is more dismal than a diagnosis of most cancers, including lung cancer. And if you have diabetes, this 5-year survival on dialysis drops to 25%. However, most people with kidney disease die before ever initiating dialysis due to the systemic effects of kidney disease on the heart and the cardiovascular system, or simply due to the lack of resources. Disparities in kidney medicine are a global issue, where socioeconomic status and other social determinants of health define who is most likely to get kidney disease and who will not receive appropriate and timely care. These are terrifying statistics. This is indeed a global public health crisis and an urgent call for action. Those of us in the kidney community already know these statistics too well. Let's make them widely known to those outside the community, and most importantly, let's change them. And we can change them. There is now reason for tremendous hope. Over the past year, medicine and science together have created, innovated, and collaborated on a public health crisis firsthand to develop vaccines and slow the spread of COVID. It is time for us to do the same for kidney disease. And this is where we move hope to action. Over the past few years in the kidney field, we have created and been witness to incredible advances and innovations. In the past 3 years alone, there's not been one but dozens of positive clinical trials. Trials with such significance that we now have the power to change the course of kidney disease, preventing millions of deaths and saving millions of kidneys. This menu of new therapies include the FASNs, the SGLT2 inhibitors, and non-steroidal mineralocorticoids, endothelin-1A receptor blockers, GLP-1 agonists, and the list goes on. And there are positive trials for glomerular diseases. In October of 2020, a FASN, an SGLT2 inhibitor, received breakthrough status from the FDA. This is virtually unheard of for chronic diseases. Breakthrough status is reserved for treatments of exceptional potential and are usually designated for rare and orphan diseases and cancers. This is the first time for chronic kidney disease and underscores how times have changed, why this is our moment, and why this is a reason to shout from the rooftops. Simultaneously, there are emerging classes of gene-targeted therapies that will correct disease-causing mutations, large data sets that have become available, and the application of artificial intelligence to kidney diseases, as well as major advances in technologies to generate bioartificial kidneys. How many of you began your fellowships, as I did, now mine, about 30 years ago, thinking you would ever be able to take a small biopsy of a skin sample or a urine sample, spin it down, take the cells, pop them into a petri dish, and add a cocktail of ingredients, push them to differentiate into a kidney, miniature kidneys in a dish? This is now possible. Moreover, equally important for these advances to happen, collaboration in our field is at an all-time high with other societies and organizations and those outside our field, the nanochemists, the bioengineers, the data scientists, and most importantly, collaborations and partnerships with patients whose voices are the most powerful and most effective. No question, we are a specialty in the midst of transformation. And now we must each do our part to shift the focus from kidney failure to kidney health, from treatment to prevention, from complacency to disruption. And we must act to combat the challenges and threats that stand in our way. Today, I will outline the 3 challenges that we must overcome. First, we must move innovation to implementation. As Dr. Rossing says, clinical trials are irrelevant if the treatments don't make it to the patients who need them. Each of us recognizes the significance and potential of the powerful new therapies. However, if history has taught us anything, this recognition and overwhelming evidence is not enough. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers have been available for decades, and yet 60 to 75% of patients who should be receiving them are not receiving them. So what can you do? What can we do as a community to ensure history is not repeated? If you are a clinician, prescribe new treatments, champion these new therapies, enroll your patients in clinical trials, share your knowledge with your peers and your colleagues in primary care and other specialties, empower your patients and become their partner. If you are an investigator, keep looking for the next great breakthrough because they are there. Build those tools and metrics that will ensure breakthroughs move forward to the patients who need them. And if your passion is policy or regulatory changes, advocate for changes to reduce the cost, increase accessibility, push for increased point of care and earlier screening for kidney disease so we can get these therapies to all patients who need them. And all of us must reach out to students and trainees. They are the future of our specialty. Mentor and coach them. Reel them in and show them why nephrology is the best specialty. And all of us must demand more funding dollars from the funding bodies to ensure these innovations continue and to ensure we move resources from funding kidney failure treatments to funding solutions and cures. And when we succeed, the FASNs alone have the power to save millions of lives around the world. A back-of-the-envelope calculation suggests that 150,000 lives and 375,000 kidneys alone could be saved in 1 year in the United States, and that number grows exponentially worldwide. And to bring it down to a single patient, the addition of this therapy to a typical patient enrolled in one of these trials can extend their time off dialysis by 15 years. If you detected urgency in my voice, you are very observant. You are right, it's there, because every day we wait leads to lives and kidneys lost. And for the next generation and superstars, the clinicians and kidney investigators who are listening in, know that your successes will bring to realization the bioartificial kidneys and will place nanodelivery and gene therapies and artificial intelligence in every nephrologist's therapeutic toolbox. The second challenge I will discuss today: we must resolve issues of health injustice. These amazing innovations and advances will fail to transform our field unless they make it to all patients who need them equitably. Over the past year and a half, here in the US and around the world, we have witnessed growing civil unrest, horrific murders, examples of law enforcement brutality, lack of accountability for genocide, and we have seen, many times over firsthand, the impact of COVID on underserved and marginalized communities. These events have laid bare disparities and rightly focused, the world lens on the horrifying truth of systemic racism, social injustice, and its consequences. We must keep the pressure on so that the spotlight remains focused on health justice if we are to transform our specialty. Here in the United States, if you are Black, you have an almost fourfold higher risk of kidney failure. If you are Hawaiian or Pacific Islander, threefold higher, and if you are Latinx, Hispanic, Native American, or Alaskan, twofold higher. Yet if you are white and have kidney failure, you are twice as likely to receive a kidney transplant than if you are Black. And these disparities exist around the world. Wherever it is possible to gather the statistics, glaring disparities in access to care are apparent in kidney medicine. As I've heard this year's Peters Award winner, Dr. Dawn Wesson, say, nephrology is the poster child of disparities. We must impact social and political determinants of health if we are to win for our patients. We must ensure the powerful new therapies and innovations eliminate rather than enhance disparities. So what can you do? First and foremost, demand accountability of yourself, of your peers, and of others. If you see something, don't sit back. Over the past 2 years, we have witnessed the power of standing up to eliminate disparity, of the passion and advocacy of medical students who stood up and demanded race be removed from clinical algorithms. Race is a social and not a biologic determinant and has no place in clinical algorithms. That passion mattered. The American Society of Nephrology and the National Kidney Foundation worked together with the community and with patients, launching a task force to make it happen in an equitable way that is patient-centered. At each of our institutions or workplace, we have seen committees launched and plans developed to address diversity and equity issues and to dismantle systemic racism. Now is the time to move these words and plans into action. It is up to each of us to get involved in your practice, at your institution, your company, your community, at ASN or other societies. And if we succeed, to reduce, no, to eliminate disparities, no longer will you walk through dialysis units whose dialysis chairs are disproportionately filled with patients who are Black or African American, Hispanic or Latinx, or from an underserved community. No longer will our patients face barriers to transplant, barriers such as income, insurance, transportation, and the race in the Kidney Donor Profile Index will disappear. No longer will kidney failure define kidney medicine. Accountability each and every day. These are large challenges to implement innovation and eliminate disparities to ensure these innovations are equitably distributed. And that brings me to challenge 3. Remember who we are. Our specialty was built on innovation. We were the first specialty to discover how to replace organ failure medically, inventing dialysis. We were the first specialty to successfully transplant an organ. We had the guts to bring a patient's struggle to the floor and to dialyze them on the floor of Congress and to change policy and ensure life-saving renal replacement therapy was made into law. We were the first specialty to remove race from a clinical algorithm nationwide and recommend a new race-free formula and a path forward. More than any other specialty, the past year of the pandemic has demonstrated what we, as a global community, can accomplish together. Overcoming incredible challenges, shortage of supplies, we developed new ways to safely deliver life-saving kidney replacement therapy. When confronted by accelerated blood clotting of dialysis lines, we rapidly devised and shared new protocols. A virus that attacked kidneys and disproportionately impacted underserved populations, affecting 50% of all hospitalized patients and up to 70% of all ICU admissions. We unraveled the mechanisms and we fought for equity. We advocated for vaccines for our most vulnerable immunocompromised transplant and dialysis patients. And at each and every step, we succeeded. We will succeed as a global effort. We do solve the most complex problems together. Each of you chose this field because of your passion and dedication. In nephrology, it's patients first, always. And because of your unwavering tenacity and determination to solve the most complex problems in medicine, we have the ability to transform our field at this moment in time, giving hope to the 850 million people living with kidney diseases worldwide. It's not without challenges to ensure these changes happen, but we don't shy away from challenges. In closing, we must say no to the status quo. It is time for us to make it known that kidney disease matters, that nephrology matters, that our patients matter. This transformation of our field that is already underway will require each of us to do our part. Paraphrasing the words of the great Martin Luther King, the ultimate measure of a person is not where they stand in moments of comfort and convenience, but where they stand at times of challenge and controversy. The challenges in front of us are clear. Now it's time for us to bring controversy. To those who refuse to acknowledge that we are in the midst of a public health crisis of kidney disease, let it be known, and if we do not act, let it be known we will be complicit with them in promoting health injustice, social injustice, and preventable deaths. My charge to you today: amplify your passion for kidney health. Elevate the patient voice and choice. Unite. We can solve the most complex problems when we work together. Be political and demand change. Adopt innovation. Don't settle. This is our time, our moment. Let us stand up to the challenges, and yes, let's bring controversy and say, I am proud to be a member of the kidney community. I want to take this opportunity to recognize the tremendous effort and dedication, and to thank this year's Kidney Week Program Committee, co-chaired by two phenomenal individuals, Dr. Deirdre Cruz, who is Professor of Medicine at Johns Hopkins University, and Dr. Ananth Karamachi, Professor of Medicine at Cedars-Sinai. Together with a committee made up of 34 international experts in nephrology from around the world, they have put together an amazing program that I know you're going to enjoy. Their names are listed on this slide. Please take a moment to read through, and please try to search them out during the meeting this year. I also want to take this opportunity to thank the behind-the-scenes crew, Jinsu Kim, Alex Zappel, Liz Larrable, and the entire ASN education team, who once again have pivoted from a fully hybrid meeting to a fully virtual meeting. Thank you to everybody, and please join me in giving a tremendous round of applause. And now it is my great pleasure to introduce Dr. Victor Zhao, President of the National Academy of Medicine. Dr. Zhao is an internationally acclaimed physician scientist whose own work and work at the National Academy of Medicine has had tremendous impact and has advanced healthcare, not only here in the United States, but around the world. Last year, ASN was privileged to have Dr. Zhao deliver the plenary session on genome editing. This year, Dr. Zhao has been instrumental in putting together this first of its kind joint National Academy of Medicine ASN opening plenary session that will feature experts in COVID-19. Please join me in welcoming and giving a huge thank you to Dr. Zhao.
Thank you, Dr. Quaggin. Certainly, on behalf of myself and the National Academy of Medicine, we're delighted to partner with ASN. Previously, we have partnered with other organizations such as international academies, the Royal Society, the Chinese Academy of Medical Sciences. We partner with government institutions and agencies, and major foundations and other nonprofits. But this is our first partnership with a specialty society. I'm very excited about this. We're certainly excited to extend our reach in collaboration with specialty societies to broaden our impact and highlight different areas of medicine. What better area than kidney disease for us to start such a relationship? So Susan, you know that this would not have happened without you, because it was you that brought the vision and foresight to me to work together to develop this program. You know, given the importance of and the relation between COVID-19 and kidney diseases, the time is right for National Academy of Medicine and ASN to partner on this plenary session to bring the most up-to-date information on COVID with a global focus on kidney disease. This session will highlight viral pathogenesis, the importance of COVID variants in development of next-generation therapies and vaccines, and provide expert opinions on public health policy and potential long-term impact on cardiovascular and kidney disease. Now, we have a great lineup of outstanding speakers for today's opening plenary. First, we'll begin with a keynote from Tony Fauci on public health lessons learned and implications for future pandemic. This keynote will be followed by a panel of experts moderated by Sanjay Gupta. So let me first introduce Tony Fauci, who obviously does not need any introduction. Dr. Fauci has provided unprecedented service to the nation as the director of National Institute of Allergy and Infectious Disease at NIH. He oversees an extensive research portfolio on infectious disease and immune-related diseases. Dr. Fauci has made many seminal contributions to basic and clinical research and is one of the world's most cited biomedical scientists. He was one of the principal architects of the President's Emergency Plan for AIDS Relief, or PEPFAR, a program that saved millions of lives throughout the developing world. He has been a trusted advisor to 6 US presidents, including, of course, currently President Biden. And during public health crises such as HIV/AIDS, SARS, anthrax, influenza, Ebola, and now COVID-19, he has been an amazing trusted voice and steady leadership. We certainly see this in COVID-19. He's offered an unwavering trusted voice to the nation and the world on behalf of science-based policy and public health. So please welcome Dr. Tony Fauci.
Greetings, everyone. This is Tony Fauci here at the National Institutes of Health, and it is a great pleasure and a privilege to speak to you today as part of Kidney Week 2021. As you can see, the title of my talk is COVID-19 Lessons Learned and Remaining Challenges. This will be a very brief overview, so let's get right at it. I've divided my very brief presentation into 6 elements. The first is a quick look at the epidemiology. We know now that beginning in the late December and 2019 and early 2020, when the first cases appeared in the Wuhan district of China, we now today have over 240 million cases and globally 5 million deaths. The United States is one of the worst hit countries with already 45 million cases and over 730,000 deaths. The distribution per 100,000 population by the darkness of the blue shade is shown on this slide. And still we are right in the middle of it, despite the fact that cases, as you can see on the right-hand side of the slide, are beginning to diminish. But if one looks at the various surges that we've experienced over the last 20 months, we can see that we want to make sure we get these cases down to a very low level without rebound. Hopefully, in the context of vaccine, this will be attainable. I'll get to vaccines in a moment. Looking at the virology, this is now a very well-studied virus. It's a beta coronavirus of the same subgenus as SARS-CoV-1 and certain bat coronaviruses, an RNA virus with a large genome, 4 structural proteins, the most important of which is the S or spike protein, which contains the receptor binding domain binding to the ACE2 receptor on tissues throughout the body, particularly the upper and lower airways, the GI tract, cardiovascular tissue, and endothelial cells. The transmission now, with the experience we've had, is very well established by exposure to respiratory fluids, either true respiratory droplets or the inhalation of aerosol particles. There's a deposition on the mucous membrane, usually of the mouth, nose, or eyes. And transmission, although this was not fully realized early on, is much less common through contact with contaminated surfaces, with the greater risk being in places with poor ventilation and certain behaviors such as exercise, hence the increased risk in gyms, singing, hence the increased risk in choruses and chorals, such as in churches. Another very important and unusual aspect of this particular infection is that anywhere between 50 and 60% of all the transmissions occur from someone who does not have any symptoms, either who will never get symptoms or who is in the pre-symptomatic stage of the infection. The clinical course for those who do in fact get symptoms are mild to moderate in about 80% of them, and severe to critical in anywhere from 15 to 20%, leading to a case fatality rate overall of about 2.3%, but up to 20% in people requiring mechanical ventilation. Speaking of severe outcomes of COVID-19, this is much more likely to be seen in elderly individuals, but as well as people of any age with certain underlying medical conditions, such as diabetes, obesity, hypertension, chronic lung, kidney, and heart disease. Shown here, some of the medical conditions that are strongly associated are listed here, but note chronic kidney disease is clearly among the most prominent. We know now from studies that have been conducted during this outbreak of something about the pathophysiology of COVID-19 associated acute kidney disease, where more than 25% of patients who are hospitalized with COVID-19 have developed acute kidney injury. Therapeutics, a very important component of countermeasures. One can divide it into two major components: targeting the virus itself, such as drugs like remdesivir, which requires intravenous administration. It's an FDA-approved drug. We have a number of monoclonal antibodies that have been very encouraging if given early on in the course of infection to prevent the progression that would need hospitalization. I would point out among the other antivirals that have been studied, one in particular, molnupiravir, which has now been shown in the clinical trial to diminish by 50% hospitalizations and deaths. That is now being considered for an emergency use authorization. Late in the course of disease, moderating the host response due to the aberrant inflammatory and immunological response by commonly used therapeutics such as dexamethasone, but also with monoclonal antibodies such as tocilizumab against IL-6 receptor and baricitinib against JAK kinase. Again, there's a major effort now in targeting antivirals to develop more orally administered drugs given early in the course of infection to prevent progression to severe disease and hospitalizations. And finally, vaccinations have really been the success story of COVID-19 and the core of our interventions. In fact, the rapidity with which we went from just noticing and understanding and identifying a virus in the first weeks of January of 2020 to then 11 months later, having more than one vaccine proven to be highly efficacious and safe going into the arms of individuals was deemed appropriately by Science magazine as the science breakthrough of the year in 2020. It was a conflation of scientific advances, including the development of new technologies in the form of platform technologies, particularly the now very promising messenger RNA technology, as well as the stabilization of the immunogen in its pre-fusion form to give maximal immunogenicity, work done by Barney Graham and his colleagues at the NIAID Vaccine Research Center. As you can see from this slide, we now have 3 platforms in vaccines that are now as part of the US government development portfolio. One of them has already received full FDA approval, the BioNTech Pfizer product. 2 have received emergency use authorizations, the Moderna and the J&J product, and the others are now in various stages of development. We have shown the field, that is, extraordinary efficacy in clinical trials, very impressive real-world effectiveness, not only in the United States, but throughout the world. But importantly, we've now faced the challenge of the impact of various SARS-CoV-2 variants caused by certain constellation of mutations that have accumulated in some of the isolates. The most important of which for us has been the Delta variant, which actually is now shown to be much, much more transmissible than any of the other variants, and in fact occupies more than 99% of all the isolates in the United States and is seen in over 173 countries. Viral loads, when measured, of Delta versus other variants such as Alpha are up to 1,000 times greater, clearly explaining the high degree of transmissibility. This challenge has been compounded by what we're seeing as waning immunity over a period of time from the time one gets vaccinated. This is particularly evident in studies from Israel, which is about a month to a month and a half ahead of us in the dynamics of the outbreak and in the distribution of their vaccines. And the Israeli study showed waning immunity, not only in protection against infection, but against severe disease. And we are starting to see that very, very clearly in cohorts that are now followed throughout the country, which leads us to the issue of booster shots for SARS-CoV-2 vaccine. And a number of studies that we've performed here and others in other countries makes it very clear of the extraordinary benefit of booster shots for getting maximal degree of protection. And again, getting back to our colleagues in Israel, have shown that when given a third dose of BioNTech Pfizer in a situation in the context of a Delta variant where the immunity has waned, there has been a 19-fold diminution in the risk of severe illness in the elderly and about a 22-fold lowering of the risk for people younger, ages 40 to 60, which leads to now, after studies and examination by the FDA and the CDC, the people eligible for COVID vaccines, the same for Pfizer and Moderna, 65 years of age or older, or anyone 18 or older, either in a long care facility or underlying medical conditions or in a high-risk occupational or living setting. J&J, anyone 18 years of age or older who were vaccinated more than 2 months ago with the J&J are eligible now for a boost. So finally, just what we know is that we are in a race against the vaccine to get ourselves optimally vaccinated and to do so to ultimately get that curve that I showed you on a prior slide to continue to come down to an extremely low level when we no longer are in a pandemic phase. I want to close by just 2 observations for you. Several years ago, my colleagues and I wrote an article in Lancet Infectious Diseases talking about emerging infections and why this is truly a perpetual challenge because of the history that we have now experienced. And we know it will come again. And a perpetual challenge requires perpetual preparedness. And in this regard, I'll close with this slide, looking forward to our ability to prepare for future pandemics. The White House has recently released a $65 billion pandemic preparedness plan that really has an Apollo program type design to transform the way that we as a nation respond to pandemics, in part by vastly accelerating our capability for vaccine development, therapeutic development, testing, and production. Thank you very much.
Hi, my name is Ashish John. I'm the Dean of the School of Public Health at Brown University and a practicing hospitalist at the Providence VA Medical Center here in Providence, Rhode Island. I'm thrilled to be with you today and really looking forward to the panel discussion. My hope is to spend a few minutes right now talking about global vaccinations, the challenges of global vaccinations, and the particular importance of people with chronic kidney disease and the reasons we need to make sure they remain a priority in our global vaccination strategy. So I don't need to tell this crowd the importance of chronic kidney disease. By 2010, the data suggested that it's one of the 20 leading causes of death and disability from the global burden of disease work. And those numbers have only grown as populations have gotten older, as hypertension, diabetes have become more widespread around the world. And so people living with chronic kidney disease remain a growing population, a population that needs more care, but also a population that's much more vulnerable. Vulnerable to cardiovascular disease and vulnerable to infections. And because of their immunosuppressed state, vulnerable to bad outcomes from COVID-19. And this really gets us to the topic at hand, which is global vaccinations. And how do we make sure that we vaccinate the world? So as of right now, as we, in mid-fall of 2021, early November, we are approaching about 7 billion doses administered into people's arms around the world. That sounds extraordinary, and in many, many ways it is. 7 billion doses, and we're doing about 1 billion doses a month. That has meant that about half the world, the half of humanity, has already been vaccinated. That's terrific. In countries like the United States, in Europe, we see relatively high rates of vaccinations. Actually, America not doing as well as many European countries, but between 60 and 65% of our populations are vaccinated. We see that in much of Latin America as well. Across Asia, China is among the most vaccinated places in the world. India is approaching its 50% mark. And other countries across Asia are doing well as well. But there are pockets of places in the world where vaccination rates remain very low. And there are pockets in Asia, there are pockets in Latin America. But the big place where the world has just ignored, has kept vaccines away, has not done its moral obligation is on the continent of Africa. About 5% of the African continent has been fully vaccinated. While much of the world is making great progress, Africa is moving very, very slowly. Why is that? Why is Africa particularly vulnerable? It's really a lot driven by vaccine nationalism. Africa has the resources to purchase vaccines. That's not the issue. The issue is that the vaccines are not available. They're not available because wealthy and middle-income countries have decided to focus on themselves first and really taking all the vaccine doses that are out there and keeping it really for their own supply. This is a huge problem because we cannot get past this pandemic until we have the whole world vaccinated. So what do we need to do? So right now, what we need to do is, again, in high-income countries, including some middle-income countries like China and even increasingly India, we are seeing a surplus of vaccines. And so first huge part of the strategy has to be getting vaccines out there and donated. Through COVAX, which is a mechanism set up by WHO to get vaccines out to countries around the world, but also working directly with national partners and regional partners. One of the organizations that I have come to believe is one of the most effective regional partners that the United States should be working with is the Africa CDC, and getting vaccines out to the African continent. That's got to be number one, get the vaccines out there. Second is we've still got to do a lot of work on building up capacity for manufacturing. 1 billion doses a month, I wish it was a day. 1 billion doses a month sounds like a lot, and it is, but it is not enough. And this is just to try to get everybody that first and second dose. People will need boosters over time. And we have got to do a lot more on increasing vaccine manufacturing capacity, particularly on the continent of Africa, to create more self-sufficiency and allow the African people and the African nations to be able to access the vaccines that the rest of the world has been holding off. Again, this is no longer an issue of resources. This is really many African countries have more than enough resources to do this. It is the difficulties that other countries have made in allowing people to purchase more vaccines. Finally, we really have to think about the priority populations. Obviously, we don't need to vaccinate everybody immediately, or not everybody is of the same priority. We've got to obviously focus on people who are older. We have to focus on people with chronic diseases, people who are vulnerable. And this is where really making sure that we are vaccinating people with chronic infections, people with cardiovascular disease, people with chronic kidney disease, particularly important, people who are high risk, of focusing on those populations. If we begin there, even if we don't get everybody vaccinated immediately, we're going to dramatically lower mortality and suffering from this virus. I think this is all very achievable. I am confident that at some point in 2022, we will have more than enough vaccines. Right now, we're still in a place where we've got to put a lot more time, effort, and resources into getting more vaccines out to the world, but particularly to the African continent. And then over the long run, we have to build a strategy where there's much greater levels of vaccine production capacity across the world. And what I have heard from my African colleagues is this is no more. This is the last time that they will leave their fate in the hands of others. I think you're going to see a resurgent Africa that is going to be very bold in building its own capacity. But that is for the future. Right now, we've really got to have a global approach, and that means getting more vaccines out to the rest of the world. Thank you very much for inviting me to this excellent event, and I look forward to the discussion.
I'm going to talk about coronavirus variants. Where do they come from? And then I'm going to speculate a little bit about where they are going. So first, my disclosures. So I'm going to give a little bit of background first. So this is the coronavirus particle. It's composed of a large 30 kilobase RNA genome complexed with a protein called the nucleocapsid protein, forming this capsid structure inside of the virus particle. And surrounding the capsid is a membrane, shown here, that's derived from the host cell when the virus is assembled. Within the membrane, there are 3 viral proteins: the spike protein that everyone's probably heard about. And this is really important protein because it attaches to the cellular receptor, and in doing so, mediates a fusion of the viral and host membranes and mediates entry. It also is important for mediating spread from cell to cell. And finally, it's also a very important target for the immune response that's elicited by the mRNA vaccine and some of the other vaccines as well. The 2 other proteins in the membrane are the membrane protein M, the small membrane protein E, and they both play roles in replication as well as in viral assembly. So I want to talk a little bit about the history of human coronaviruses and the spillover of these viruses from animals into humans. So we first heard about human coronaviruses back in the 60s and 70s when OC43 and 229E were reported to cause the common cold. From that time until about 2002, there was a lot of basic coronavirus biology research carried on, and it was a pretty obscure field, but there were a bunch of us working on it for during all this time period. So that in 2002, when SARS coronavirus emerged in southern China, it was quickly identified as a coronavirus, and as we know, caused severe acute respiratory disease. And it was the first of several viruses to do so. And we learned at that shortly after that SARS had its origin in bats and was transmitted to a civet and then to humans. And again, this was in 2002. And just after that, HKU1 and NL63, 2 further non-lethal coronaviruses were identified. And following that, in 2012, Middle East respiratory syndrome coronavirus emerged in the Middle East. It also was shown to have a bat origin, to be transmitted through camels into humans. And then finally, in late 2019, we all know now that SARS-CoV-2 emerged in a different part of China, in Wuhan. And this virus almost definitely has a bat origin. We don't know really if it has an intermediate species, and it was clearly transmitted to humans in 2019. But we also know now that probably all these common coronaviruses also have their origins in animals. OC43 was transmitted from cattle or pigs to humans in the late 19th century. 229E is believed to have come from bats to camels to humans in the late 18th century, and NL63 from bats to humans in the 13th to 15th century. And the reason I think it's important to think about this data is because it illustrates that coronaviruses are all zoonotic, or we think they are, and they evolve as they spread into and among humans. And I think that the variants can be thought of as SARS-CoV-2 continuing to adapt to optimize spread among humans. And I want to talk now a little bit about the viral spike protein some more. The spike protein is the site of most of the genetic changes in variants. And the spike protein will help us to explain why we have variants, quote, of concern. So here, all coronavirus spike proteins are divided into 2 subunits, S1 and S2. S1 contains a receptor binding domain. That's the part of the protein that is critical for attaching to the host receptor and to infect cells. And so therefore, this domain, or this part of the spike, is very important for virus entry. S2 contains the so-called machinery for fusion. It actually mediates the viral and cell fusion. And this TM here just means transmembrane domain that attaches the spike protein to the membrane. Then another important part of the molecule is this site here, this S1, S2 cleavage, so-called cleavage site. So there has to be a cleavage or cutting of the protein right down the middle into S1 and S2. And this is mediated usually by a protein called furin, a protease, and it recognizes a run of basic amino acids at the intersection of S1 and S2. And this is really important for virus spread, and I'll show you in a minute why. And then in addition, the spike protein is the target for the antibody response generated by the mRNA vaccine or by the adenovirus vaccines as well. And so antibodies are generated that recognize sequences or epitopes all along the spike protein. And it's clearly the ones that recognize the receptor binding domain that are most important for neutralizing the virus. Now I want to explain how variants arise. And variants arise during normal replication of coronavirus genome RNA. So here's the very long genome RNA. And it's copied or it's translated into a replicase complex. And this enzyme then copies back the genome into a negative strand copy of the genome called the antigenome. This enzyme then copies back more positive strand genomes that are going to go into progeny virus. Now, this replicase, or RDRP as it's called, is quite error prone. So every time it makes a copy or makes a new genome, it might have an error or mutation in it. And we see these at random places in the viral genome. And usually they're either have a negative effect on replication or no effect, and they just kind of die out. However, if a mutation occurs in the spike gene, and this mutation may confer a selective advantage for replication or spread, a virus with this genome will emerge as a variant and kind of take over the population. So let's look at the spike protein again and why some of these variants are of concern. So here's the alpha variant, or the UK, what was used to be called the UK variant, and it has mutation, this important mutation in the receptor binding domain, and another one in this furin cleavage site that I just mentioned, and some other ones in S2. The beta variant, or the South Africa variant, also has mutations in the receptor binding domain, and another one here. And then the Delta variant that we've been hearing about a lot lately has mutations also in the receptor binding domain and also in this furin cleavage site again. So why are these of concern? Well, there's several reasons. One reason is that they may confer increased receptor binding. This N501Y mutation that's present in both of these variants will do so, and perhaps the Delta receptor binding domain variant mutations as well will confer better binding. And the second reason is this furin site, again, this proline to histidine mutation or proline to arginine mutation. Each one of them will make this cleavage site a more basic sequence of amino acids, and that will cause increased cleavage of S1 and S2. And this will potentially allow the virus to cause more cell-to-cell fusion and viral entry as well. Now, there are also, and then the third reason is immune escape. So this E484K mutation is in an important epitope recognized by the antibody. So mutation of this epitope might reduce somewhat a particular ability of a particular antibody to neutralize the virus. And in addition, mutations in other genes may contribute to giving this virus an advantage for replication as well. But these are the three main reasons I think that these variants have been of concern so far. And just to illustrate, this is cell-to-cell fusion caused by SARS-CoV-2 infection, and this is a tissue culture cell line. This is from my own lab. And you can see here the green represents viral replication or viral protein. The blue are nuclei, and you can see these very large so-called syncytia with many nuclei in them. And they're really just evidence of viral spread, cell-to-cell spread. This is A549, a long-derived cell line. We also see this in a more primary kind of cell. These are cardiomyocytes made from induced pluripotent stem cells. And you can see here that we also see some multinucleated cells, not as large as we see in the cell lines, but we can see some cells with 2 or 3 nuclei. In this image, the green again represents viral proteins, and the blue is nuclei. The red here is just a marker for the cardiomyocytes. So, and as I said before, the mutation of proline to histidine or arginine will probably confer more cell-to-cell fusion and better spread of the virus. These are some data gathered by my colleague, Rick Bushman, that plot the accumulation of variants of concern over the last 8 months in the Delaware Valley. And we can see here, we can look on the left here, that during early March, during the spring, we see that the alpha variant and some other more minor variants, iota, mu, are accumulating during those few months of the spring. However, by the time we get to the summer, almost everything we're isolating here from patients is Delta or something related to Delta. So Delta has clearly taken over as a predominant SARS-2 isolate. So I want to consider, lastly, questions to consider going forward. Thank you for your time.
Thank you for inviting me this morning to talk with you about our society's COVID-19 response team. Since February 22nd, 2020, our response team has built web pages with information that have had more than 70,000 downloads. We've developed podcasts related to COVID-19 that have had more than 50,000 downloads. We developed posters for the dialysis facilities related to infection control and COVID vaccines that have had more than 5,000 downloads. The response team has developed frequently asked questions and acute kidney injury documents that have had more than 10,000 downloads. We produced 20 webinars with more than 50,000 attendees, and we held Twitter chats in collaboration with NephJC on March 17th, 2020, related to COVID-19 in general, that had more than 4 million impressions, more than 1,500 tweets, and more than 270 participants. On September 21st, 2021, we held a Twitter chat related to monoclonal antibodies and vaccines that had more than 9 million impressions, more than 1,000 tweets, and more than 170 participants. We've partnered with community agencies, including the American Association of Kidney Patients, the American Kidney Fund, the American Nephrology Nurses Association, the CDC, the National Association of Nephrology Technicians and Technologists, the National Kidney Foundation, the Renal Healthcare Association, and the Renal Physicians Association. We've collaborated with dialysis organization chief medical officers and held more than 49 calls and counting to date. We've partnered with the American College of Emergency Physicians, the Council of Medical Specialty Societies, the American Society of Transplantation, the American Medical Association and the CDC, the Society of Critical Care Medicine, and the Kidney Community Emergency Response Coalition. On Easter weekend 2020, we partnered with New York City healthcare organizations to evaluate the need for continuous dialysis supplies during the acute surge that the city experienced. We've also reached out during surges in California, North Dakota, Washington State, and Wisconsin to society members. We've partnered with numerous government agencies, including the Assistant Secretary for Preparedness Response, the CDC, the CMS, the Department of Defense, the FDA, the Department of Health and Human Services, the National Governors Association, and the White House. We've advocated for increased amounts of PPE, dialysis access surgery, waivers, increased use of telehealth, and increased access to critical care for patients on dialysis. We've advocated against herd immunity. We've advocated for vaccines for patients on dialysis, and we've advocated for increased use of monoclonal antibodies for patients with kidney disease. We partnered with the Assistant Secretary for Preparedness Response to hold the Scarce Resources Roundtable on July 28th and 30th of 2020. We developed online learning modules. The first was developed to prepare people for a COVID-19 surge. It had more than 5,500 views, more than 600 of which occurred within 12 hours of posting. And on September 10th of 2021, we developed a mental health, wellness, compassion, fatigue module that had more than 850 visits within the first 30 days. In terms of presentations, we've had more than 30 media interviews, dozens of community presentations, and more than 20 peer-reviewed articles in journals, as you can see listed there. Our team has been led by our co-chairs, partnering with Alan Kleiger, who's been a friend, a mentor, and a leader. It does truly take a village. We've had four subcommittees, one led by Vinita Kumar, one led by Jeff Pearl, and one led by Anitha Vijayan. Our CDC representatives have been Anna Cecilia Bardassi, Stephanie Booth, Shannon Novosad, and Priti Patel. Our team has worked with Christina Bryant, Debbie Cody, Alpa Kisler, Nikki Lurie, Liz McNamara, Glenda Roberts, and Matt Sinclair. The 56 members of our subcommittees, who you'll see on these slides, have participated in more than 100 meetings. Our outpatient dialysis subcommittee, which I've led, our home dialysis subcommittee led by Jeff Pearl, our acute kidney care subcommittee led by Anitha Vijayan, and the transplant subcommittee, which was led by Michelle Josephson until she got elected to our council, and since has been led by Vinita Kumar. Finally, I want to thank our ASN staff, the Excellence in Patient Care team led by Susie Stark, as well as Bonnie Freshley, Carrie Lee, Darlene Rogers, Matt Howard, Javier Rivera, and Colin Richardson. Our legislative and policy team, Rachel Meyer and David White. The education team led by Laura McCann, and the innovation team led by Mark Lynn. Finally, I'd be remiss if I didn't thank ASN's leadership, particularly our council, led by President Sue Quaggin, and our Executive Vice President, Todd Ibrahim. Thank you.
Hello, my name's Amitabh Banerjee. I'm Professor of Clinical Data Science at University College London, and I'm also a cardiologist at Barts Health and University College London hospitals. Today, I'm going to be talking about long haulers and implications for public health and COVID. And I should say that long COVID is the term that we use rather than long haulers on our side of the pond, but it's interchangeable. These are my conflicts of interest, and importantly, I do work both clinically and academically. So this Lance editorial by Richard Horton coined the term in relation to COVID-19, the syndemic, which is how a cardiologist ends up working in the field of COVID-19. So syndemic is a convergence of an infectious disease, undertreated non-communicable diseases, and social determinants of health in a syndemic rather than a pandemic. And this is relevant to chronic diseases such as chronic kidney disease. Here on the left of the slide, we showed that 20% of the population in the UK fell into the so-called high-risk population for hospitalization and mortality from COVID-19. And on the right of the slide, you see that the baseline mortality of people with chronic kidney disease is only surpassed by people with COPD, and the more diseases that you have underlying, the more comorbidities, the higher the risk. And that's what drives mortality from COVID. And when we published this paper in May, we showed that if the infection rate was allowed to rise to 10% or more, there would be over 70,000 deaths in the UK. And of course, this sadly did play out. This was confirmed by the Open Safely project run by Dr. Ben Goldacre. And again, chronic kidney disease does indeed lead to increased risk of COVID hospitalization and mortality very clearly. So these are direct effects of the pandemic, but there are also indirect effects on individuals with chronic kidney disease and other chronic diseases. We showed that cancer services were reduced during the pandemic. We showed that reduced rates of endoscopy occurred, and we also showed that there was an impact on people with cardiovascular disease, and particularly when they themselves had underlying comorbidities, including chronic kidney disease. So long COVID occurs on the backdrop of direct and indirect effects of COVID. But on the left of the slide here, we conducted the first study to look at multi-organ impairment in long COVID, showing that 70% of people in this cohort, 200 patients 4 months after their initial illness, these were largely non-hospitalized. So 70% of them had a single organ impaired, and 30% had 2 or more organs affected. On the right of the slide, we looked at over 45,000 individuals who had been hospitalized with COVID with the Office for National Statistics in England, and we showed that over 10% of them were dead within 4 months of being discharged from hospital, and 30% of them were admitted to hospital. So even if you recover from the acute illness, there can be chronic effects, and also there's new disease in the form of diabetes, new chronic kidney disease, new cardiovascular disease. And in this analysis of over 270,000 patients in US veteran care data, analysed by colleagues in the University of Oxford, the panel to look at is the bottom left here, that shows when we look at long COVID symptoms, the prevalence of long COVID symptoms are no less in non-hospitalised than hospitalised, and in fact can be more. So being hospitalised or not does not necessarily make the major factor for whether you have long COVID. Long COVID is an entity that we have to view through the public health lens, and the best way to prevent it is to avoid being infected in the first place. And we need to make sure that vaccination is as high as it can be at population level. But we need to also recognize and refer appropriately, manage and rehabilitate, and try and get people back to the community as quickly as we can at health system level. In a large NIHR-funded study, Stimulate ICP, we're looking at 3 aspects over the next 2 years. We're looking firstly at current care evaluation for the disease across England. We are secondly conducting a large, pragmatic, cluster randomized trial of an integrated care pathway, including the cover scan, which is multi-organ MRI, and also a digitally enhanced rehabilitation platform. And embedded within this trial, there is a drug platform study where initially we're looking at antihistamines, a combination of famotidine and loratadine. The primary outcome here is fatigue on the fatigue assessment scale at 3 months. We're also, in the third part of the project, looking at inequalities and how we can improve referral rates in harder to reach populations and looking at the transferability to other long-term conditions. So people with chronic kidney disease and other chronic diseases are affected directly, indirectly, and in the long term by the pandemic. And chronic kidney disease is acting as a risk factor, as a disease, and as an outcome from infection with SARS-CoV-2. So the key take-homes are that infection suppression is best. We need to improve vaccination and manage underlying chronic disease, as well as the long COVID, long tail of the pandemic that we're seeing around the world. Thank you for your attention.
So let's move to the panel discussion. The panel will be moderated by Sanjay Gupta. Sanjay is a multiple Emmy Award-winning chief medical correspondent for CNN and a member of the National Academy of Medicine, and we're very proud of him. Dr. Gupta has covered some of the most important health stories in the United States and around the world. Throughout 2020 into 2021, Sanjay reaffirmed his role as a trusted guide to viewers worldwide on navigating between facts and fiction surrounding COVID and the pandemic. So please join me in welcoming these world-class experts and Sanjay, who share their invaluable insights and experience to advance the knowledge of global gathering. Let me turn over to Sanjay.